A very good morning to one and all. So I'll be speaking on non-contact ultra-wide field sweat source OCT biomarkers predicting treatment response of anti-VEGF in aggressive ROP. So these are my affiliations. I do not have any financial interest. So in the last 5 or 6 years, three things has changed. One thing is non-contact wide field imaging has helped us in diagnosis and treatment management in ROP, mainly because of the quickness of image capture and the non-contact nature. Another thing that has changed is smallest or the tiniest of babies are surviving. So even the 26 weekers and 28 weekers are having good neonatal care. So we are encountering more and more aggressive ROP. And the third thing that has changed is anti-VEGF has become there is a paradigm shift from laser to anti-VEGF in the last 4 or 5 years because of the better anatomical outcome and better even visual acuity, as well as chances of refractive error is less. So these three things have changed uh, in the paradigmly in the last 4 or 5 years. So the objective of this study is mainly to find out, is there any biomarker that could predict when a baby comes with an aggressive ROP like this. So yes, we know we have to give an anti-VEGF when the media is clear and there is no traction. But how do we predict when to call this baby, or what will happen to this eye, whether it go for a crunch phenomenon, whether it go for a peripheral avascular retina, or whether it will reactivate much faster than others. So the main objective was to find any biomarkers. Yes, there are studies that have shown fundus biomarkers and fundus fluorescein angiography biomarkers and also tear film based biomarkers, but all these are more subjective. So probably this is one of the objective way where OCT biomarkers for the first time has been tried in neonatal eyes. So the exclusion criteria, as I said, systemically unstable babies, or if there is any traction or previously treated eyes, or if there is any media haze or pupillary poor dilatation where we could not capture the images. So we included 40 babies and 80 eyes, and we followed this baby after giving anti-VEGF. We followed this baby up till 4 months of time, and the follow-up was 1 week, 3 week, and after that based on the judgment of the vitreoretinal surgeon who was taking care of the baby. So group 1 is a favorable outcome where the mature retina was reached. Group 2 is unfavorable outcome, that is crunch phenomena, reactivation of peripheral avascular retina. So is there any baseline OCT biomarkers that could predict which one of these babies with AROP go to group 1 or group 2? So the standard flying baby position, where all the precautions of covering the baby with warm clothing was taken, and we had a neonatologist or a anesthetist in the ground or in the floor where we captured these images. And the Swepsod OCT biomarker, OCT image capturing device, that the Opto Silverstone was used. It has a fast image acquisition of 0.4 second and also very high infrared radiation of 1050 nanometer with very good depth penetration and very fast image capture, and horizontal line scans were used. So we saw the biomarkers. So what we found out was two important biomarker that caused an unfavorable outcome was mainly your hyperreflectivity of inner retinal layers and your choroidal thinning. Whereas a good favorable outcome was seen if the retina was normal or if it had a hyporeflective cystic spaces. So for example, if you see this baby had a hyperreflective inner retinal layer with choroidal thinning, and after injection within 1 week it went for a crunch phenomenon with the traction. And the second baby we can see here, it also had a significant inner retinal layer hyperreflectivity, and the vessels did not progress beyond zone 2 posterior even after 3 to 4 months, and eventually ended up in laser after subjecting into general anesthesia. Whereas the babies which had normal retina without any changes or which had a hyporeflective cystic changes, as in this image, these babies tend to do well and faster progression after anti-VEGF injection. And with the anti-VEGF monotherapy of bevacizumab, that is 1/3 of the adult dose of 0.4 mg in 0.05 ml itself, they completely matured within a span of three months. So this is one image. If you can see, this is the same baby's different eyes. One eye had normal retina. The other eye of the baby had hyperreflective inner retinal layer. So it had a poorer progression compared to the fellow eye. So even in same baby also, this was seen to be true. So one important thing is anemia is the strongest systemic risk factor we found out among all the systemic risk factors. So anemia correction should be an integral part of your treatment of babies. So what this study adds on is, yes, there are baseline non-contact ultra-wide field swept OCT biomarkers along with the fundus imaging could be the one which could help us to predict which are the eyes which go for favorable or unfavorable outcome. Yes, hyperreflectivity of inner retinal layer, choroidal thinning should alarm the treating ophthalmologist that these babies need a much closer follow-up and these babies can go for an unfavorable outcome. Whereas cystic spaces and normal looking posterior pole, they have a much better favorable outcome with faster progression post anti-VEGF in AROP eyes. So this is our team from LVPI, and we had a lot of team because 20 team to take care of this advanced technology with tenderness of care. So thank you for giving the opportunity.
What do you feel about this? There's a arterial occlusion, you feel like how we get in the patient with a CRAO. So it's a very severe ischemia, right?
Yes.
What I'm trying to say.
Yes.
It's reached the posterior pole, it's like a retinal artery is getting affected at the entrance of the so that's what's reflecting. So the ischemia is high, that's what you're trying to say, am I right?
Absolutely, sir. So far, the point of view that people have looked at is foveal maturation and development. True. We have looked this in the form of, as you have mentioned, central retinal artery occlusion or central vein occlusion or ischemic diabetic macular edema. In that point of view, we have looked at it.
Right. Any other factors you looked at besides this hyperreflectivity? You found anything else?
Another thing is choroidal thinning, sir.
Choroidal thinning.
Yes.
That's also a high risk factor.
Yes. Yes.
That also suggests a global ischemia is what.
Yes. Yes.
Great. I think it's a very good study. I think very great.
You said cystic changes. What does it indicate?
So
do you see in a normal eyes?
Yes. So the landmark study by Maldon-Adaldehyde in JAMA has showed that 50% of the normal preterm babies can have cystic changes at the fovea. In our study, we have seen 23% of the babies having cystic changes. In their study, they showed that there is no connection between cystic changes and the severity of ROP. In our study, since we looked at the treatment outcomes, we found out that these cystic spaces could mean a good prognostic indicator.
That's opposite of seeing cystic changes in other retinal diseases where it's a poor indicator, which here is good indicator.
Even in vein occlusion, if you see cystic spaces like 500 microns, they immediately respond to injection. Even in BRVOs, if you see cystic spaces, means they will respond better to anti-VEGF.
Increase anti-VEGF activity. Probably respond well.
Dr. Akash, two questions. One, you have a differential presentation in two eyes, in different eyes, in a single baby. So how can you explain that, first one? And second is that, do you feel that giving anti-VEGF in these patients where vasculogenesis is progressing, in these patients where you have a non-favorable outcome, did it change whether we can avoid anti-VEGF in these patients, or have you seen anything different in these patients?
Thank you for the question, sir. So AROP eyes, now the shift is towards anti-VEGF because we cannot laser till zone 1 arcades for various retinal detachment or refractive error. So anti-VEGF is the treatment of choice. What I showed was even in the same baby which had one eye hyperreflective inner retinal layer, other eye normal, the other eye normal progress much more faster than this eye. So yes, something that we need to keep in mind and tailor make our follow-up. Lot of things has to come from here on regarding the follow-up, how to tailor make to these eyes. That is coming on our next publication. We are finding.
You are using the word normal eye, but it's the immature, premature.
Sorry.
Yeah.
Yes. Yes.
So you are using every other normal eye.
Yeah.
I think looking at this thing, they are not normal eyes.
Yes.